and it could be periodontal pain. These pain conditions are absolutely different pain conditions. You know, when you investigate the patients, the patient pain will be different when the patient suffering from a palpal pain, then a dentin pain, then a periodontal pain, because the palpal pain is a so-called visceral pain, you know, visceral. So the palp is a visceral organ located in a closed cavity inside the tooth, and the visceral organ pain, the palpitis, is a very sensitive, very disturbing pain condition, maybe similar or nearly similar than the trigeminal neuralgia. As you know, the trigeminal neuralgia is a very large, intensive pain condition, and the visceral pain is similar, and it is characteristic for this pain condition, the palpitis, that it is initiated without stimulus, you know, without any stimulus. But when you have periodontal pain, for example, periodontitis, the stimulus is necessary for the pain condition. So the pain initiating factors and the investigation are very important, you know, because when you ask the patient, is there any irritating factor or irritation initiating the pain, and the patient and the pain is very intense, large, lancinating type of pain condition. It could be palpitis, you know, and when the factor is, for example, biting on the tooth, it couldn't be palpitis usually, but it is periodontitis, because the periodontitis is a different type of pain. It is a musculoskeletal pain, okay? The periodontium is part of the musculoskeletal, generally musculus. It is a musculoskeletal structure. Like your muscles and joints, periodontitis is actually functioning as a joint as well, or periodontal membrane, sorry. And so you should know that we have different structures, can respond different pain or can reflect different pain conditions. The pain could be localized, well localized, could be sharp, could be dull, could be irritating, and it could be an acute pain or chronic pain. These are different conditions we have to discuss, and we have to write down, document in the clinical practice, you know, because it is very important to record the patient dental status. And we have tissues which are painful, for example, the dentin. The dentin is a sensitive issue. As I mentioned, the palp could be very painful, but the enamel is not painful. Enamel is not a living tissue, it is not painful. Even the bone is not painful. But there are certain conditions in which you have to manage this pain from the bone. For example, in a surgery, in a periodontal surgery, it is important. And we have discussed that there are certain peripheral elements. These peripheral elements will be responsible for the peripheral pain perception. Okay, we have the free nerve endings, non-myelinating fiber endings, of course, and we have different fibers from different neural cells. A delta fibers, myelinating fibers, sharp the velocity or the action potential propagation of these A delta fibers are faster than the C fibers. So the C pain condition, C fiber behind the C fiber, it is dull, diffuse, and not well localized pain condition. For example, in palpitis, okay. And in acute condition, for example, in dentin sensitivity, and sometimes you may feel the pain in two stages. As I mentioned you, the first stage would be the activity of the A beta fibers, because as you can see, the velocity is much higher of the myelinated fiber, A beta fibers, than the C fibers, okay, than the C fibers. And so we have these afferent nerves, afferent pain responsible for the pain perception, okay, afferent nerves. These are C fibers, A beta fibers, but we have other fibers, A delta fibers, sorry, and we have A beta fibers. These are mechanoreceptors, or these fibers are ended in the vessels, in the walls of the vessels, okay, walls of the vessels. So these are the fibers of the pulp, fiber types of the pulp. These two are responsible for the pain, but the third one is not connected to the pain, but only mechanical perception. For example, as I mentioned you, in the vessels and the dilating of the vessels, or similar. We have mentioned that we have a lot of free nerve endings and penetrating the dentin tubules, but only in the pulpal end. In the pulpal end, it is penetrating into 100 micrometers. The dentin is penetrated by these free nerve endings with 100 micrometers. And these nerve endings terminating or ending near the odontoblastic area, okay, near the odontoblasts. And we have different nerve endings, okay, we have different nerve endings. How this picture is about how the nerves and the ends of the nerves are terminating in the pulp around the odontoblasts, around the odontoblastic cells. And we have marginal fibers. Marginal fibers means these nerve endings are located between the odontoblastic layers. We have simple predentinal fibers, one fiber, these are not branching, but ending, not branching, ending in the predentin, okay, predentin. And we have complex predentinal fibers. The fibers are ended in the predentin, but these are branching as well, so branching into two ends, okay. And we have dentinal fibers, deeper fibers, okay, not predentinal, but deeper fibers, but only penetrating the dentin with 100 micrometers. So the periphery of the dentin is not innervated, of course. So we don't have nerve endings in the periphery of the dentin. It is very important because when you drill the tooth, when you prepare the tooth, tooth cavity or decay is cleaned, drilled, you will see that the periphery will be of the dentin. So when you reach the periphery, just under the enamel, the periphery, near the dentino-enamel junction, is very sensitive for the patient. And the next layer will be also very sensitive, is the innermost layer of the dentin. So there are two layers, the periphery and the innermost layer of the dentin, which are very sensitive. But the mid layer is not very sensitive of the dentin. Why is it important? Because we have to explain why the dentin is sensitive. So how the pain and sensitivity is perceived in the dentin. Okay, we have to explain. But with simple nerve transmission, you cannot explain the dentin sensitivity. Why? Because nerve fibers are not located at the periphery of the dentin. I said you the periphery is sensitive, but no nerve fibers. So nerve transmission is not enough. There is something other way behind this thing, behind this dentin sensitivity. This figure is the same, but graphical of the previous one than the previous one. Okay, the same. So we have different fibers: marginal fibers, simple predentinal and complex predentinal fibers, and we have dentin fibers inside the dentin. Marginal fibers between odontoblasts, simple dentinal fibers with one end, okay, single-ended fibers, and we have complex fibers with branching, and we have deeply penetrating, not more than 100 micrometers, but deeply penetrating dentinal fibers, okay? And this is the Rashko plexus, you know. From the Rashko plexus, you have the thinner endings toward the odontoblastic layer, yes. The dentin sensitivity, you know, as I mentioned, in connection with the dentin sensitivity, you have to consider the following things. So we have tuberous inside, and the tuberous content is very important, the fluid inside the dentin. So these may be responsible for the dentin sensitivity, and only the pulpous third of the dentin contains odontoblastic processes, and the nerve fibers are only the very shallow pulpal layer, in the very shallow pulpal layer. And the question is, how can the dentin transmit painful stimuli? This is the question. But we have here the discussed anatomical things. We have explanations or theories for dentin sensitivity. Okay, these three or some say four explanations we have in the literature, you know, in the international literature. So we have the nerve-mediated explanation of theory, nerve-mediated. Of course, we have nerves in the dentin, and maybe this nerve will transmit the pain, okay? And odontoblastic conduction theory, we will explain this later. I'll just figure out. Odontoblasts can perceive stimuli, peripheral stimuli, but there is some problem with this explanation, namely that, as I mentioned you, there are no synapses between the odontoblasts and the fibers. And the synapses are important elements for the action potential propagation from one cell to the other cell. But we have only gap junctions between these nerve fibers ending and odontoblasts. And that is the good, accepted, generally accepted theory. This is the hydrodynamic theory of dentin sensitivity. And that is another theory, maybe in the Lensburg book, it is said that odontoblast migration theory, migration of the odontoblasts. You know, not the odontoblasts are migrating, but it is really the case that when you irritate the odontoblast, some element of the odontoblast processes, for example, is moving somehow, and maybe, so it is not a well described theory, but we have this force theory as well. We have different dentin types as well. And,
sorry? In the previous lecture, the nerve mediated means it's not accepted because we have peripheral dentin.
I will explain this here, okay? Here, yes. So this is the accepted, you know? This is the accepted. Sorry, but I will not answer this, but later. Okay? So this is the accepted hydrodynamic theory. We have a stimulus, for example, drilling or preparation of the dentin, air blasting, you know, air blasting, and hypertonic solutions, for example, very sweet maltesers can initiate pain, okay? And this stimuli can induce fluid movement inside, fluid movement. And this fluid movement or streaming will disturb the peripheral nerve circumstance area, so the disturb the peripheral nerves near the odontoblastic layer and initiate action potential, okay, of the thinner endings of the A delta fibers. And the outer layer of the dentin is very sensitive. Why? So when the question in the exam is why the outer layer is sensitive, the answer is that in the outer layer we have a lot of ramification, branching of the tubules, okay? And you know, when you have very narrow tubules and ramification of the tubules, in the narrow tubules, the streaming is even faster than in wide tubules. Yes, because it's fluid movement or fluid streaming flow of the, this is the so-called thick flow in yes, because of the capillarity streaming. So you can see here the evidences and you know, so these statements for this theory, for these statements basing the hydrodynamic theory. So when you press or when you place a cotton ball onto the surface of the dentin, this cotton ball will dry the dentin locally, and this irritation will suck out the fluid from the dentin tubules, okay? And when you decrease the pressure and when you place an absorbent paper onto the surface of the dentin, this will initiate pain, okay? Because this will increase the outer flow, okay? So when you place a dry absorbent paper onto the surface of the dentin, the fluid, because of the absorbent sucking activity of the paper, the fluid will transmit toward the enamel, okay? Outward, fluid movement or streaming is occurring when you apply this absorbent paper. Sometimes, of course, you dry the dentin surface, and when you dry the dentin surface to see the cavity, okay, this activity will be painful for the patient because the outer layer of the dentin will be sensitive. And when you place a hypertonic solution onto the surface of the dentin, okay, again, the hypertonic fluid will suck out the dentin fluid, and an outward streaming is induced by this hypertonic solution. And the result will be, again, fluid movement. So the fluid movement could be outward, fluid, and inward. What do you think, which is more painful?
Outward.
Out, yes.
Toward the tubules branches.
Yes. The out is much better. Yes. But, you know, when you place cold, for example, when you would like to estimate the vitality, cold test, or electrical test, but cold test is used. Cold will initiate out movement. So the hot will initiate inward fluid movement. But the cold is better tester. cold. So then the tooth is alive, so in vital tooth. But and this is the reason why you apply cold test and not hot test when you would like to see the vitality. Cold or electrical testers are used because these are valid and sensitive tests. But hot is not. But when the tooth is necrotic, okay, necrotic with gaseous material inside, the hot is useful, hot, because this will increase enlargement of the gaseous material, the necrotic material inside the pulp, okay? And when you etch the dentin, so etching of the dentin surface will open the canaliculus, the dentinal little channels will open the etching of the dentin, and when the dentinal tubules are opened, the patient will feel sensitivity, okay? But when this dentin channels are closed, even with toothpaste, for example, Sensodyne is used to close the channels, the canaliculi, dentin canaliculi. And the nerve-mediated theory, you can see here clearly the statements for and against, okay? The statements for and against the nerve-mediated theory, okay? So when you would like, so when your question is that could be nerve-mediated theory behind the patient dentin sensitivity, there are some statements for this theory. For example, yes, we have nerves inside, and we have other things. For example, the numbers of the nerve endings or the branching of the nerve endings is very low number of the free nerve endings, and these nerve endings are not penetrate the freshly erupted teeth, you know. So in newly erupted milk or primary teeth, we don't have branching, nerve branching inside the tubuli, and no nerve in the outer side of the dentin, but the outer side of the dentin is very painful. So this is against. So with question mark, it is against, okay? And when you apply topical anesthetic solution onto the dentin surface, these topical anesthetic solutions, so your theory could be that this will anesthetize the nerve endings, and this will seize the patient sensitivity. But when you apply to the topical anesthetics to the dentin surface, this will not be effective. The patient will feel the pain further because it is not a good way to anesthetize the dentin. Okay. And the odontoblast theory, conduction theory. So basically, the odontoblasts are similar in origin than the neural cells because they come from the neural crestal originating cells. So theoretically, they can transmit. Yes, the membrane of the odontoblast is able to transmit the propagation of the pain. Yes, it is true. But no synapses, so it is against. No synapses, against. So this couldn't be the explanation for the sensitivity. And the odontoblast membrane potential is very low. You know, membrane potential is very low. So yes, for the stimulation and propagation of the action potential. So the membrane it is not enough to propagate the action potential and to you know, from jump out from one cell to the other cell because it is very low, the membrane potential. So this is the problem, that the membrane potential is low, so the odontoblasts will not functioning as neural cells in the dentin, okay? And no odontoblastic processes in the outer layer of the dentin because they found that only, normally in the vital in vivo circumstances, only the inner one-third of the dentin is penetrated by odontoblastic fibers, inner one. But the outer third, 2/3, are not. So again, the outer part of the dentin under the dentino-enamel junction is very sensitive, but no odontoblastic processes. It means the odontoblastic processes are not responsible for the patient sensitivity and pain. And again, the topical anesthetics, okay? Topical anesthetics. Again, it is not working on the dentin surface. It is a clinical finding, okay? Because you should use injections, solutions, but not topical anesthetics to lower the patient pain, okay? Topical anesthetics are not working in healing or trickling the tooth. But when you respond to the odontoblastic processes for pain, it means theoretically that the topical anesthetics should work. But in the clinical practice, we know that these topical anesthetics are not working. So no odontoblastic response is for the dentin. And the other topic, the permeability of the dentin. Permeability of the dentin. You know, this is the other topic, permeability of the dentin. And we have a lot of dentinal tubules, and the dentinal tubules number and frequency per square millimeter depends on the area of the dentin. In the inner side of the dentin, we have a lot of tubules, you know, in the inner side, even 70,000 dentinal tubules per square millimeter we have in the inner side of the dentin. So a lot of tubules, but in the outer side we have only some thousands, tubules per square millimeter. And so in the inner side, the diameters is wider than in the outer side, because from the palm area to the enamel, these are tapering, okay? So the outer side is narrower, but the inner side of the tubules are wider, tapering, because of this tapering. And the diameter of the tubules, you can see here, the average diameter near the palm is 1 micrometer, but below the enamel it is 0.2 micrometers, okay? 0.2 micrometers, the average diameter of the tubuli, average diameter. So you can see here the average numbers per square millimeters, average diameters. I mentioned you the inner area of the palm of the dentin is perforated more with this tubuli, okay, with this tubuli. And when it is open, you can see here the dentin, and here the peritubular dentin or intratubular dentin, which is more mineralized, and the intertubular dentin. Okay, so we have here the orifice of the dentin tubule near the dentin surface, in neck sensitivity. So when you have a picture about neck sensitivity, these orifices or openings of the tubuli are free, not blocked by some so-called smear layer. Maybe you know this smear layer of the dentin from endodontics. I don't know, but you will. Okay. You can see here empty tubuli, and when the tubuli are empty and not filled or blocked by smear layer or by crystals, oxalate crystals, for example, from Sensodyne toothpaste, okay? Sensodyne can block these tubuli, okay? And reducing the sensitivity, But when these are opened, free, not blocked, you will experience sensitivity because the permeability of the dentin is very high, the permeability of the dentin. And the oxalate crystals I mentioned you from Sensodyne can block the opening orifices of the tubers. Okay, crystals can artificially block it is very important. For example, here oxalate crystals. This is the tuber, it is blocked by on the surface by minerals, okay, from toothpastes. And when you apply, or when you drink Coke, for example, when you drink wine, you will wash away this block, and your dentin will be sensitive after Coke. Or when you brush very vigorously, similar, you will free the.
This on the dentin, how does it come?
It's the dentin, periphery of the dentin.
Yeah, but you're not discovering it, so how does it enter?
No, when
When it's
its next
exposed?
sensitivity, it is exposed.
When it's exposed, okay, so.
Only when it is exposed. And the other components, you can see here the odontoblastic processes. Here, odontoblastic processes, there are molecules, macromolecules, collagen, and other albumin, transferrin. Collagen, we have here the 1, 4, and 5 type collagen, proteoglycans, and we have, of course, neural elements as well. So we have odontoblastic content of the dentin, molecular content of the dentin, of the tuber, and we have, of course, the fluid. So besides the fluid, we have other components inside the tubuli. Okay, inside the tubuli, we have other components inside the tubuli. Odontoblastic processes, proteoglycans, macromolecules like collagen, transferrin, albumin type molecules, and we have neural elements as well. But this may modify the penetration of the molecules and when you have decay, caries, you will see that the byproducts of the bacteria can penetrate the tubers, but when you have sclerotic dentin and the peritubular dentin is very extensive, the penetration of the dentin is reduced, okay, penetration of the dentin. So in the decay, when you have a decay, we have the sclerotic area of the decay. So when the decay, the caries is propagating slowly, the undermost layer of the caries or the decay will be the sclerotic dentin, okay? Sclerotic dentin, and in this sclerotic dentin, the permeability of the dentin is very low, very low. This is the function of the sclerotic dentin. And the material transport can be occurring in two ways. Material transport, how different molecules, even bacterial or byproducts, bacterial byproducts can penetrate the dentin, okay, can penetrate. There are two ways it is important, basically it is important, so you should recognize this. We have the diffusion, okay? And of course we have the fluid streaming, okay? But here, this is the diffusion, okay? The diffusion of the molecules, for example, when you have a well concentrated calcium solution, and the outward calcium content is higher than the inward calcium content, of course, the calcium will diffuse from out to inside, because the concentration, okay, the concentration of the calcium is higher outside than inside, and the concentration gradient will lead or will regulate this calcium flow, and it is under the fixed second law. So we have so-called diffusion rate and the diffusion coefficient, and the material transport will affect these diffusion rate and diffusion coefficient, but the size of the area, the size, you know, because when the area is larger, the calcium transport, for example, or diffusion is higher, of course, and there is a concentration gradient which is different for different molecules. So the dentinal fluid and the extracellular matrix is concentration gradient is different for the calcium than the potassium. So it depends on and the length may affect the diffusion rate. So one way is the diffusion, and the other way is the hydrodynamic theory, regulating the Hagen-Poisson law of fluid movement. This is the fluid movement or fluid streaming in the dentin. Okay, fluid movement. Of course, we have tubuli and we have capillarity inside this, and this capillarity streaming fluid movement is under this physical law of the fluid streaming. Okay, so you should know this, the basics of this because for the exam, because we have a specific topic about this. And so the fluid movement is depending on the pressure difference. So outward pressure of the fluid and inward pressure. Outward and inward pressure will affect the streaming of the fluid, okay? And we have the radius is very important here. So the diameter is very important of the tubuli. When you have small diameter, and as you can see, it is forward and the fourth degree. So the diameter is a very important factor. When you increase the diameter, the dentin tubular diameter, with 2 times, the
velocity is higher. It's opposite. So when you increase the radius, you decrease the velocity, and the other way around.
Yes. It is decreasing. The volume. No, this not velocity, volume.
Volume.
Sorry, it is volume. Fluid movement volume, not velocity.
But fluid movement is velocity. Volume.
How much fluid?
How much fluid passes through?
Yeah.
Yes. How much fluid?
So increase the radius by double, it gives 4 times.
Yes, 4 times higher in a month. So
No,
it is
16
decreasing a
times.
little bit, but it is volume, not velocity. Yes, good sense. So radius and viscosity of the fluid may affect the fluid streaming, and the volume is transported through the tube. And of course the length again will affect the transported fluid volume.
Thank you so
Okay,
much.
so this is the basic thing. These are the basic things